sets the stage for the eyelid. And the upper cheek and the malar area, what we call the cheekbone, is the foundation for the lower lid. So one of the principles that I'm going to talk about today are looking at adjacent structures. I see a lot of people come in and they're interested in eyelid surgery, and eyelid surgery is one of the most common types of operation that I do, but we also need to look at the adjacent areas. So Belisa, thanks very much for the introduction to the importance of the eyebrow. As you all probably know by now, I'm Dr. David Morwood. I'm a plastic surgeon. I'm board certified. We started the seminar series a couple of years ago called The Truth About Plastic Surgery. We started it for people who worked in salons and estheticians and beauty experts, etc. And then it's expanded to the general public because of popular demand. Basically, the title tells everything. I'm going to give my own personal opinion, my personal viewpoint about what the truth is about plastic surgery, because I think there's lots of misconceptions. I'm going to show you lots of actual before and after pictures. We're going to show you some diagrams. Everyone that we show is my patient, unless I point out that it's from a magazine, and they've given permission for us to use it in educational context. So, as I said, eyelid surgery is one of the most common things that I do in my practice in plastic surgery. The eyelids have been called, the eyes have been called the windows to the soul. And now, as Felisa gave a great introduction, the eyebrow is really very important. The ideal feminine shape for the eyebrow has a gentle upward slope for the first 2/3 towards, as it's going laterally, or towards the ear from the outside. And then there's a peak at about the junction of the outer third. And then at that point, the ideal female brow can come down a little bit, or it can be horizontal. Now that varies slightly from the ideal male brow in our society, where we accept a low brow in a man, oftentimes a horizontal brow, that can be a sign of masculinity. Sometimes I lift the brow in men as well, but I'm much more conservative. So one of the things that we like to emphasize, in addition to the shape of the brow, and by the way, that goes for any ethnic group. It's not limited to Caucasians, etc. And below that, we like a full upper lid. We don't like to see lax tissue. We don't want it to be too full because that gives the impression of puffiness. And for the lower lid, ideally, there's a smooth, what I call an eyelid cheek junction. I'm going to talk about that a little more. Now, most of the models that I'm going to show you, and if you pick up a glamour magazine, all the glamour magazines show gals who have a smooth lower eyelid traversing to the cheek. That's a very smooth eyelid cheek junction. Now, those are all airbrushed, and it tends to look sort of mannequin-esque if it's overly dramatic. They're all airbrushed. But the point is that the eyelid, the lower eyelid should have a smooth progression into the cheek, and that serves as the foundation for the lower eyelid. Now, as I said, for the male brow, it's slightly different. We like a horizontal. We can accept a horizontal brow. Now, sometimes people say to me, "So why is it called plastic surgery? Is it because you use a lot of plastic and silicone?" Let me pause for one moment. I wonder if everybody could put their cell phones on silent. If that would be okay. So the reason why it's called plastic surgery is because in Greek, plastiko is the same root as plastic surgery, and that means to mold, shape, and tailor. That's how we got the term plastic and plastic surgery. Plastikos, mold, shape, and tailor. Sometimes I see people in the office and they'll say, "You know, Dr. Morwood, I know you operate overseas and you take care of children and cancer and car accidents and all that stuff." And I feel somewhat vain coming in. I want everybody to keep in mind it's normal, natural, human nature to be concerned about your appearance. That's normal and natural. Everyone wants to look their best. If we see someone on the street who doesn't care about their appearance, well, that strikes us as odd. We recognize that person as sort of a kilter in some way. So it's normal. Everyone wants to look their best. And eyelids are very important. Again, a lot of what we see in the glamour magazines are airbrushed, lots of makeup, etc. But I show some of these examples because it gives us a representation of some of the principles that we aim for. A full upper lid, an eyebrow that shapes upward and then horizontal or slightly down, and for the lower lid, a smooth eyelid cheek junction. And as I said before, it doesn't matter the race, ethnicity, that goes across the board. You see the full upper lid with a slope of the eyebrow as we head towards the ear. Now, of course, the face is a very powerful tool of communication. Number one, of course, is the voice. Number two, it's the face and the eyes. So the face and eyes are a very powerful tool of communication. Number three, for those of us who speak with our hands, that can help. Our limbs do communicate a lot. And of course, body language is important. But the point I want to make is that second only to the voice, the face and the eyelids are an important tool of communication. Now, let's talk about some signs of aging, whether it's the cheek or the face or the eyelids, etc. First of all, we need to look at the skin. The skin is the first structure really to take the brunt of sun exposure and laxity. Now, fat. As we grow older, we tend to lose fat in our face and we gain weight in the trunk. We lose fat in our face and hands and gain weight in our trunk. Now, fascia is the covering on top of muscle. It's one of the connective tissues within the body underneath the skin. That can get lax. Muscle, of course, less tone and mass. Cartilage, we lose resilience. However, sometimes cartilage can grow larger. Like as we get older, in fact, our nose and ears can get larger. Now, bone, the craniofacial skeleton, actually can get smaller as we get older. So, some of the changes that we see with aging are predictable, some are not. But the point that I want to make is that every patient deserves a custom designed approach. If you're going to take home one lesson, it's this slide right here. Every patient deserves a custom designed approach. I'm not an advocate of getting in line and having the same cookie cutter approach that everybody gets. You can go on the internet and see this magic lift and this quick lift and this thing. And I think everybody, especially for eyelid surgery, facial surgery, neck surgery, everyone deserves a custom designed approach because not everyone ages the same. And of course, we don't start out with the same face. So some of these aging signs are predictable, some are not. So let's see. At this point, I'm going to ask my expert Chantal to come on up and show me what I can do about this. So there's a few principles that I want to emphasize. So the eyelid, thank you so much. The magic of audio, video. So we've talked about a few principles. So the eyelids themselves are of vital importance, but the eyebrow is the roof of the upper lid. What we call the cheekbones, the malar area, and the zygoma serves as the foundation for the lower lid. So we want a full upper lid. We want the eyebrow to slope upward gently, and we want a smooth lower eyelid cheek junction. And we talked about the difference between men and women in our society. So for women, we like a gentle upper slope to about the middle 2/3, or the outer 2/3. For male, we like kind of a horizontal or more horizontal brow that can be lower. So we accept that. I talked about how I sometimes will lift the male brow. I'm much more conservative when I do that. We need to look at adjacent structures. So, what are some of the things that we can affect for the upper lid? For the upper lid, I think that primarily we can affect extra skin. Oftentimes, people will come in and they'll say to me, I have so much upper extra skin, sometimes it's resting on the lashes. And that's, when the skin actually rests on the lashes, that's called lash ptosis. Now that's different between true eyelid ptosis, when the actual eyelid itself obstructs some of the pupil. And so, but both of those are causes of what we call visual field obstruction. Both of those incidences oftentimes can be covered by insurance. Insurance doesn't cause cosmetic surgery, but it does cover things like reconstructive surgery when the vision is obstructed. So true ptosis is when the eyelid comes down to a point where it obstructs the vision. Lash ptosis is where the skin rests on the eyelashes themselves. So primarily for the upper lid, we address extra skin. Oftentimes people come in with an excess sort of fullness in their upper lid. That's primarily the medial part of the upper lid, that's toward the nose. That's oftentimes very full, and people will come in, especially women, I think women more than men, they present with what we call those pouches of the upper lid. I tend to be not overly aggressive, but I do like to sculpt that part of the upper lid that's close to the nose. Toward the outer portion of the lid, towards the ear, that lateral third, that's where the lacrimal gland is, where the major tear producer is behind the lateral part of the lid. So we will oftentimes, we can sometimes sculpt that area, remove a little bit of extra skin, but I don't like to minimize the fullness in the lateral lid because that tends to give kind of a hollowed out appearance. Now, what about for the lower lid? For the lower lid, it's almost the total opposite. Sometimes people come in with what they, with what they call pouches, and they say, well, I want you to take away a lot of skin. But if you take away a lot of skin from the lower lid, then the danger, of course, the risk is that it tends to pull the lower eyelid down. That tends to contribute towards ectropion. So I tend for the lower lid to be very conservative in my approach to the skin, but we are primarily aiming towards smoothing out that eyelid-cheek junction. Now, I handle the fat in different ways. We all have fat around the eyeball that cushions and lubricates the eyeball itself. And in certain families, ta-da! How are we doing? Liz and Chantal, thank you. So, meanwhile, back at the ranch, some of the signs of aging are predictable and some are not. So, this slide is also very important. Remember when I said that the take-home lesson, if you're going to take home one lesson, it is every patient, client, customer deserves a custom designed approach. Well, the other key important lesson, I think, certainly, for good surgery, you need to have an accurate knowledge of the anatomy. Good surgery starts with a good, accurate knowledge of the anatomy. Because when we do an analysis in my office, whether it's with the Vectra, and later on I'll talk about the Vectra a little bit. The Vectra is a new system. There's 6 cameras connected through a computer, and it does 3-dimensional analysis, and we can sit with a person and rotate the face, and it has a breast module and body module, etc. But we need to go layer by layer. So the point of the slide is that we start with the epidermis, that's what we see. But underneath the epidermis is the dermis. That's where the strength is, that's where the blood supply is, and that's where the collagen is. The collagen is the major building block protein of the soft tissues of our body. Underneath that, that's the subcutaneous tissue, that's the fatty layer. On top of the muscle is the fascia. Then we have the muscle, of course. Then overlying the bone is the periosteum, and then there's the bone itself. So we have to go layer by layer. The way that I prefer to do a consultation in my office, whether or not we do the Vectra, is to sit with a person and we can look at the computer image of the Vectra or we can look in a mirror together. I like to hear from a person what they want to change. What do you want to change? And then I'm happy to give my opinion and to give someone feedback about what I see. And we do talk about realistic expectations, etc. But it starts off with what is it that you want to change. We need to go layer by layer. So, as I said, there are 2 major layers in the skin, the epidermis on top of the dermis. But if the truth were known, of course, there's about maybe 6 or 8 layers of the skin. But for intention purposes today, epidermis on top of dermis. Now, the enemy of young, fresh-looking skin, of course, even for Californians, or I should say especially for Californians, is the sun. Chronic sun exposure, photoaging. This leads to something called dermoelastosis, where the skin becomes atrophic, dyspigmented, wrinkled, unelastic, and leathery. Where do people get this? Sun-exposed area, the face, the hands, chest, etc., and the arms. So, we can actually look under the microscope if we do a skin biopsy, and we can see changes. It's just not something that we can see with the naked eye. We can actually see changes in skin that have been exposed to the sun. For example, here's a biopsy of some skin that has not been exposed to the sun. Here's the same person, a biopsy right near what we call, some people call it a sunspot, liver spot, lentigo, etc., an H spot. So dyspigmentation is important, and the very top layer of the skin, the keratin layer, is not even living. That can become thickened, etc. Very top layer is like nail or hair. It's not living. So I'm a big believer in skincare. I'm a big believer in estheticians and having your skin evaluated by a plastic surgeon or dermatologist and getting facials. Skincare, I think, is great. Now, what are the skincare essentials? The first step, we need to teach people to avoid the sun. Even though it feels so great, It just is not good for our skin. So we need to avoid the sun or wear sunblock. Properly cleansing, that's very important, and an esthetician can help you categorize and adjust the way you cleanse your skin. Exfoliation, that's when we slowly or rapidly in the operating room remove the very outer layer of that epidermis. Restoration, that's when we're encouraging the baby cells in the germinal matrix to grow, and we want to turn on that factory. So what we need to keep in mind that it takes about 30 days for a new baby cell to get to the top where you can even see it. 30 days. So sometimes I have people start on skincare and they come back in 2 weeks and they say, you know, I don't notice that much difference. Well, they haven't even given their skin a chance to go through one shedding cycle. So just imagine if you go through that 30 days and then you go through that cycle 6 or 12 times if you stay on it for 6 or 12 months. So it really can help when we really turn on that factory. Moisturizing is very important. Now, apart from avoiding the sun, avoid smoking. There's so many oxidants in cigarette smoke. It's bad for the vascularity, it's bad for scars, there's more infection, etc. So avoiding sun, avoiding smoking, properly cleansing, you're about 60% of the way there. Now, just very briefly, if you see a dermatologist or plastic surgeon and you want to start on good skincare, you're likely to get a skin categorization. It's Fitzpatrick 1 through 6. In summary, number 1 are those people from northern Scandinavia, Ireland, who never tan but they burn, very fair-skinned, all the way down to people from the darkest part of Africa who never burn. They have very dark or black skin. Most people are in the middle, so you're going to get categorized. It's what we call a Fitzpatrick categorization. Okay, so what about some non-invasive treatments? As I said, I'm a big believer in estheticians and facials, microdermabrasion, fruit acid light peels, IPL, that's an intense pulse light. Some of you know about that. It's very good for dyspigmentation and some vascularity. Now, I list radiofrequency, external ultrasound. Those are newer treatments that are being investigated. Now, what about a little more invasive? I'm going to talk about Botox and Dysport. People have questions. They come into me and they say, well, what's the difference between Botox and Dysport? Keep in mind that the actual active chemical is the same. It's the carrier molecule that's different. Fillers, it comes off a shelf. They're sterile in a syringe. We use a needle to inject them where we want them. Peels, that's when we use a chemical, typically an acid, to rapidly exfoliate. I believe in that. It's good. Ablative lasers can be good for some things. Dermabrasion essentially is standing down. And essentially, sclerotherapy is injection for veins, etc. Now, epidermis is on top of the dermis. Keep in mind, as I said, collagen is the main building block, main building protein within the dermis. That's important. There are some treatments, there are some minimally invasive treatments that actually increase the collagen in the dermis. It results in more collagen, more orderly layers of the collagen, etc. Retinoic acids, vitamin A, retin A, okay, most people have heard of retin A, that can actually increase the collagen. Vitamin C, some CO2 lasers and some fillers can actually increase collagen deposition in the dermis. For example, I don't want to go through this whole list, but vitamin C preparations can actually stimulate collagen growth, as can vitamin A, or retinoic acids. Increase collagen synthesis, increase cell regeneration, decrease melanin production, you know, when we talk about age spots, sunspots, liver spots, etc. So here's an example. You see the thickness of the dermis and the matrix that's producing those cells that's undergone skin care. We're going to biopsy 6 months later, and you see much thicker, more collagen, thicker, more vascularity. So it can really work. I believe in it. However, please keep in mind, the cosmetic treatments that I'm talking about, laser, etc., they do not remove extra skin or dramatically tighten loose skin. And I think that's really important. If somebody's going to have laser, there's a key indication for that, primarily for the texture and very superficial finish of the skin. If someone has laser and they expect laser to do a facelift for them, I think that results in a higher percentage of dissatisfied patients. So I think that's important. The cosmetic treatments do not remove extra skin or dramatically tighten loose skin. Now, the converse of that is true, that a plastic surgery operation cannot operate away wrinkles. So remember I said we're going to return to that principle, that every patient, every client or customer, there's a custom designed approach. We need to go step by step. Do we need to affect the texture of your skin, the finish of your skin? Do we need to rearrange tissue? Do we need to tighten? Do we need to firm? What is it that we need to do? I think it's really vital. Okay, so with all these options, there's surgery, of course, facials, peels, Botox, microdermabrasion. You know, what's a person to do? Every client, there's a custom designed approach. I'm a big believer in that. If you go to some of these places where you get in line and they take a template and you get a cookie cutter approach, I think if you have the kind of aging and the kind of face that fits into the template, you're in luck. If you don't, then I think you're more likely to be dissatisfied. Now, the reason I show this, Danielle was kind enough to find this on the internet for me. It's because when the only tool you own is a hammer, the whole world looks like a nail, right? So we want to offer the broad spectrum of what a patient or client needs. Mario's there. Okay, so for example, I'm not down on laser. I'm not down on it at all. A friend of mine from up north lent me this slide. It can affect the texture, finish of the skin, and that's good. But don't expect it to replace a facelift. And the converse is true. We need to separately treat the finish and texture of the skin from an operation where we tighten or firm up or rearrange or refill or revolumize, etc. Now, I use this as an example. You can take some fresh meat like bacon out of the package. It's soft and supple, right? And then you apply heat to it. Absolutely, 100% it's going to shrink. But it becomes brittle, easy to break, right? And my idea, like I talked about skincare, we want to have supple, hydrated soft tissues, right? We want them to remain supple. So you think you have to be very careful when you heat a protein enough to make it contract like that, expect it to dramatically tighten skin. I think you have to be very careful about things like that. Okay, again, in the glamour magazines, it's almost like a mannequin, but we can use some of those photographs to help guide us for our goals, our objectives. Okay, so what about a TCA peel? I mentioned laser. TCA peel is something that I like. It's an application of a chemical. In a small area, we do this all the time in the office. A larger area, like the entire face, typically people want to go to the operating room for that. I sometimes do it in conjunction with a facelift or eyelid surgery, etc. So, here's an example of a gal who has some dyspigmentation and some fine lines and fine wrinkles. She had it in conjunction with some tissue firming in the operating room. What happens with a TCA peel? Essentially nothing. Nothing for 4 or 5 days. Nothing happens for about 4 or 5 days. Then, for 4 or 5 days, people will exfoliate pretty rapidly. It's almost like the worst sunburn you ever had where the sheets come off. But what's left is much smoother, finer skin. So let me back up real quickly. So see how the texture of her skin kind of needs to be buffed up and affected. So she gets some firming and tightening, rearrangement of the tissue, and there it is. That's TCA peel in combination with a neck and jowl mini lift. Here's another example, just some fine texture changes, dyspigmentation. That's after about 7 days. Like I said, nothing happens for 4 or 5 days. Then someone exfoliates for 4 or 5 days. Smoother skin. And again,
so from beginning to end of that procedure, how many days? How many days?
That right there is about 4 weeks.
So it would be like a month recuperation.
Oh, no. Oh, that's a great question. Let me show you one more. Okay, that's at about day 7. Okay, smoother. Okay, so great question. So TCA peel on day 1. Nothing happens for 4 or 5 days. Then for about 4 or 5 days, people will exfoliate. And then at that point, after about a week, you can put on makeup and go to a dinner party. Yeah. I'm going to talk a little bit about dermabrasion. Dermabrasion is really effective for perioral, the sort of cigarette lines. Gals come in and call them lipstick lines because the lipstick kind of runs up. That's a lot more rigorous because we're going deeper. But a TCA peel, Danielle, about 2 weeks, right? 2 weeks people put on makeup and they go to a dinner party. 3 weeks. If you're going to have it at the same time as a surgery, pretty much by the time you're over the surgery, your PCA, your skin's ready to go. Okay, so we talked about resurfacing. I want to go a little bit deeper, no pun intended. Botox. I love Botox. I use it a lot for the upper third of the face. It's great for relaxing glabellar furrows. It's really good for smile lines. We can do some brow shaping with it. Essentially, it's a muscle relaxant. I first was doing Botox when I did my fellowship at Children's Hospital for children with some facial asymmetries. It really works. That was over 25 years ago. I think it does work. We can do some facial sculpting that I'll talk about later. It's actually started out as a medical treatment for children that have esotropia, cross-eyed, wall-eyed, etc. For any muscle spasm, we can use it. Any place where there's a hyperactive muscle, hyperhidrosis, excessive sweating. There's good results in certain patients with migraines, especially for tension migraines. Now, there are three main depressors of the brow: the corrugator muscles, the procerus muscles, and the orbicularis muscle. Now, those are three depressors of the brow. There's one main elevator of the brow. That's the frontalis muscle. So if we selectively get the depressors to relax, then we let the elevator take over, we can do a micro brow lift with Botox. And I like to do that selectively because, as I've shown a number of times, it's the lateral third of the brow that we want to elevate more than the medial third. Okay? When I say medial, I mean towards the nose, and the lateral is toward the heel. So we can do a mini or micro Botox lift by affecting that. In addition to minimizing glabellar furrows, what the company likes to call the 1s and the 11s and the 111s, and softening the so-called smile lines. So I want to show you a few examples. Here's a gal who her co-workers told her she always looked angry, and she was never angry. That's her about 2 weeks later trying to make that same expression. Here's a gal, similar kind of thing. She thought she has great skin. She thought those furrows, what she calls the 11s, made her look angry. So she gets Botox. The first effect is in about 3 days. The maximum effect is in about 2 weeks. It lasts for 3 or 4 months. So here she comes in 2 weeks later trying to make that look. So it works. I like it for the upper third. Again, I don't want to bore you, but Botox is great for that. Now, and it works for guys. Now here's a guy who didn't like the sort of crepiness and fine lines on the outer, so that's him trying to make that same expression or squinting. Again, softens those glabellar lines, gives you a little bit of a lift. Now, what if someone has a pretty deep furrow and they get some result from the Botox, which we expect, but they want to have a little more effect? Now I'm going to introduce the concept of a filler. A filler is different than Botox. A filler is like collagen, Juvederm, Restylane, etc. That's a volumizer. So she came in and she got improvement from the Botox, but she wanted more improvement, so we took a little bit of filler and helped fill in that line. In the glabella, we need to go very superficially. I don't like to go deep, of course. Some very important vessels in that area. So I'll talk about filler later, giving high cheekbones, etc. But a filler can help minimize glabellar furrows if a person doesn't get enough improvement for their satisfaction with the Botox. So there she is after a little bit of Botox and a little bit of filler. Now again, squint lines, sort of smile lines. I don't know whoever came up with that word or that term, crow's feet. I like smile lines. So again, there he is with the squinting lines, the smile lines, and here he is 2 weeks later trying to do that after the Botox. Okay, so I talked about laser, I talked about TCA peels, I talked about Botox. Now, what about filler? There are many, many fillers. It seems like every few months we get a new filler. Juvederm, Restylane, Radius, Perlane, Sculptra, etc. There's two big categories. Those made of hyaluronics, which is like Juvederm and Restylane. Those are calcium-based, which is Radius. It's a volumizer. It allows us to restore volume or create volume. Keep in mind that Botox is a muscle relaxant. It's a muscle relaxer. So we oftentimes can use them in conjunction, but they're not exchangeable. They're not interchangeable. They're different. So Botox is a muscle relaxant, and as Dysport, a filler is a volumizer.
So it fills lines, can plump tissue, and we can do some non-surgical facial sculpting. I think they're great. I love Radius and Juvederm Ultra UC to create higher cheekbones, bring the chin forward a little bit. I think they're okay to fill in lines. I think they can fill in furrows okay, but I think to fill in fine lines, I think there's probably better treatments. Now, as I said to you, all these cases are my own patients unless I point this out. This is from New Beauty magazine. This is a gal who had lots of fillers and lots of Botox, the so-called liquid facelift. So it can get some results. Okay, so as I said before, as we mature, we lose fat in our face, we lose fat in our hands, and we gain fat in our trunk. Well, wouldn't you know it? In one of those areas, the mid-face, as we lose fat, we tend to be more susceptible to the gravity, the downward pull of gravity, which tends to pull on the lower lid. So, I want to introduce the concept of fat grafting. I talked about fillers, right? It's a volumizer. Fat grafting is when we do some conservative liposuction. Same person, conservative liposuction. We purify the fat or decant it, spin it down, and we re-inject that fat to somewhere else. For example, we can do a little conservative liposuction of the tummy, and we can re-inject it for cheekbones or to fill in areas where there's been a loss of fat. It's more of a procedure, of course, because it's a little bit of a surgical procedure. We do this in the office for small areas, but people need to be numbed up, and it's a procedure. A filler comes in a box, right? We take it off the shelf. It's sterile. It's in a syringe. We attach a needle to it and inject it. Fat, we harvest it, but it's your own tissue. It's your own cells. Roughly 76% of the volume will stay. And people say, well, how long does it last? About 76% of those cells will survive. If you gain weight, they get bigger. If you lose weight, they get smaller. It's your tissue. So the difference between fat grafting and fillers. They're both volumizers, but one is your own cells, one is a product. Okay, so natural fillers, I said, stem cell rejuvenation. I just want to mention stem cells for a moment, and the great raisin principle. I'm going to come back to that. Sometimes you'll scan the internet or you'll find a magazine, somebody claiming to do a stem cell facelift. I'm board certified, I'm a member of the Aesthetic Society, I'm a member of the American Society for Plastic Surgery. Those terms are not advocated by plastic surgery. It's true that we bring up some stem cells when we do liposuction or fat grafting, but it's only about one cell out of 156. So only about one cell out of 156. So certainly there is some rejuvenation of the tissue, especially if we take it from an area that has not been exposed to the sun a lot, deeper fatty layer. We can take some of those cells and re-inject them, but it's not really a stem cell facelift. The great raisin principle I'll return to. There must be somebody here besides me who likes Rodin. Okay, now I talked about some minimally invasive things, non-invasive things. Let's talk a little bit about surgical procedures, how a plastic surgeon, how I approach facial rejuvenation. In general, we approach the face by thinking in thirds. The upper third, the middle third, and the lower third of the face. That's important. Now, some of the signs of periorbital aging are predictable. The brows come down. It can oftentimes look like there's more extra eyelid skin than there is. There's laxity, glabella furrows, the lower lids can come down, more prominent eyelid cheek junction. I'm a big dog lover. There's our Shar-Pei. Some of those dogs actually get blepharoplasty. Okay, so eyelid rejuvenation. Texture changes, pigment lines and furrows, skin, pouches, position, adjacent structures. If I'm going to do effective eyelid surgery, we need to look above and below. Sometimes plastic surgeons are accused of being general contractors, like if somebody were to call their general contractor and say, I want you to replace my kitchen countertop, but we've got to look at what's supporting the countertop, and we've got to look at the back wall too, and the shelves above. But for adjacent structures, the cheekbones, right? All the glamour models have high cheekbones. Cheekbones are, the cheek is the supporting structure for the lower lid. The brow is the roof of the upper lid. Okay, so let's look at how we can affect the brow, the forehead, and the eyebrow lifts. And the eyebrow. There's lots of ways we can get there. And again, we like to aim for a gentle slope up for 2/3 and then horizontal or gently sloping down. Any ethnic group, the same rule applies. Full upper lid, gentle sloping eyebrow, minimal cheek eyelid junction for the lower lid. Okay, here's a gal who is good looking, but she felt like she had a tired look with some glabellar furrows. Brows are kind of low, as you can see. She had a brow lift. As you can see, it just gives a more open, kind of a more vibrant look. That's the effect of bringing up the brows. Again, gentle tilt upward, full lateral brow. Now, as I said, he's certainly not my patient, and I wouldn't dare to lift his brows because, as I said, in our society, for some men, even a horizontal brow, somewhat low brow, is a sign of masculinity and virility. We like that. Now, at certain times, though, the brows in men can be so low that it obstructs the vision. So we oftentimes can pick those up, and we do less eyelid surgery than someone thinks they need because we pick the brows up. So you see the difference? So we go from kind of a tired out look to someone who's just more vibrant looking, right, refreshed, virile. Here's a guy, good looking, blue eyes. Man, eyes like that, people would just do anything for. But his brows are just low, a young guy. So we just pick those up to show off those blue eyes. So I will do that for a man, but not as aggressive as Morwood. And this guy also, his brows are so low that the eyelids are affecting his vision, so we can pick those up, etc. So we can see again. Okay, so again, we approach the face in thirds. One of my favorite ways to get to the lateral brow is by making a small incision in the temple and the hair-bearing skin. So here's a gal with really good skin, good-looking gal, but so you can see her brows are kind of low and horizontal, and it gives the impression of really heavy upper lids. By just picking up the lateral brow in a conservative upper blepharoplasty, it can just brighten up her whole look. So I did that through an incision up in the hair with a conservative upper blepharoplasty. Now, endoscopic brow lift, we can make small incisions in the scalp, and we can take, it's like a little laparoscope, it's like a telescope. Let's slide down, we can actually see the nerves and vessels. This is a photograph showing the nerves and vessels. The sort of traditional coronal approach can still be done, but I do that less often than when I do the mini incision or endoscopic approach. As I said, some of the changes are predictable for the brows and the periorbital area. Once again, we've got to go step by step, layer by layer, and look at the anatomy. That's the way that we get effective, satisfying surgery. Now, when we address the eyelids themselves, of course, the complicated anatomy of the eyelid has to be tended to. There is muscle, there is skin, there is a fat, there is fat, of course. That needs to be approached step by step. Okay, so eyelid rejuvenation. Again, these are just some of the things that I approach for the upper lid. I think primarily it's the extra skin. For the lower lid, it's the fat pouches and eyelid cheek junction. So let's look at some cases of upper eyelid rejuvenation. For the upper lid, extra skin, I'm very conservative with sculpting the fat, and we can affect the crease. So here's a gal who came in, she just wanted a simple procedure. She didn't want a brow lift, doesn't really need it. She just wanted a crease. Her upper eyelid skin is just so heavy, it's just about resting on her lashes. So in the office, takes about an hour. So you see the difference? Just kind of gives her a more awake look. That's upper blepharoplasty, upper eyelid. Some people call it an upper eyelid tuck. Upper blepharoplasty. We can do that in the office. Similar kind of thing. Very heavy upper lids. Just a more bright, vibrant look, more youthful look. Good for guys too. Sometimes we lift the lateral brow a little bit. Extra skin resting on his lashes. This gives him a much more awake look. I don't want to bore you. I just want you all to get an idea of what upper blepharoplasty or upper eyelid tuck. Yes, ma'am.
How much downtime does that require?
I think that's a great question. I'm going to address that at the end, but let me kind of
cut to the chase and answer your question. For eyelid surgery, you have to rest and take it easy for 3 days and 3 nights. Doesn't mean lay in bed, it means take it easy, 3 days and 3 nights. On day 4, a little bit more activity, but I tell my patients don't get your blood pressure up high. On day 11, slowly get back to your right. On day 11. Most women, most men, after about 2 weeks, after a blepharoplasty or eyelid tuck, after about 2 weeks, they're willing to go to a dinner party.
They're really what?
Go to a dinner party.
Seriously?
See, that's what I'm talking about. After about 2 weeks, people are generally able to sit with someone at this distance and have dinner. So where am I here? Okay, so puffy eyelids, creating a crease, etc. Here's a young guy who's a model. He wanted his creases to be more prominent. Upper eyelid. I'll leave some time afterward for questions, okay? Again, good-looking gal, just some extra skin, gives her a more youthful appearance. Now here's a gal who didn't need a lot done. She had lateral hooding, okay? Sometimes and she didn't want a brow lift, but there's lateral hooding. Just a conservative upper blepharoplasty, not aggressive. Okay, so what about lower eyelid rejuvenation? We need to look at the fat pouches. We've got to look at the septum. I'm very conservative for skin of the lower lid. And we need to look at the position of the lower lid itself as well. So there are fat pouches that I talked about. Sometimes I address only the fat pouches. Sometimes it's the fat pouches and the skin. There's my basset hound with the black lower lids. Boy, I love to operate on those. Okay, now I want to talk a little bit about the lower lid. Now this is real important. There's something called a tear trough. Sometimes guys and gals come in, they say this groove that's in the medial part of the lower lid. When I say medial toward the nose, right? This groove where the lower lid meets the cheek or the nose, that's the tear trough. And I can get deep and cast a shadow, make people look tired. Where the lower eyelid meets the cheek, that's called the eyelid-cheek junction. So, in fact, it's not just that people have lower lid pouches. It's that there's a defined junction between the lower lid and the cheek. And remember all the glamour models that we're seeing? Even if it's makeup or they air blow these pictures, it's almost like a mannequin. But to have a smooth eyelid-cheek junction for the lower lid is important. So sometimes that's all we want to address. And if you're going to have an eyelid-cheek junction, we want it to be a little bit higher than down almost on the cheekbone. So, for example, she's got some pouches, but really the key issue is that she has a prominent eyelid-cheek junction. So we want to affect that and smooth it out. Okay, do you see the difference? We go from there to there just to get that eyelid-cheek junction to be smoother. Eyelid-cheek junction prominent. I'm going to reposition some fat, tighten up the septum, and that's done on the inside of the lower lid. Okay, can you see how that's smoother? Hopefully it's projecting on the screen. Okay, so sometimes I go on the outside if someone needs a little pinch of skin removed, but very conservatively. Sometimes I go on the inside of the lower lid. And that's called a transconjunctival approach. Now, in some families, I can see their teenagers, and sometimes younger than teenagers, that septum, that membrane that holds the fat in place can get lax, even in kids, and the fat can start to protrude. So here's a pretty young guy who has just prominent lower eyelid pouches. And that's transconjunctival approach. That's at about a week. Here's a gal, same kind of thing, really good skin, doesn't have any extra skin, prominent lower eyelid pouches. We smooth those out. Here's a guy a little older, prominent eyelid-cheek junction. We want to smooth that out. We don't want those pouches there. We don't want that prominent junction. We just want to smooth that stuff out. Again, three-quarter view. Here's a gal who's got some puffy upper and lower lid. So we can do that in conjunction, smooth things out. Again, I don't want to bore anybody. I just want you to get an idea of what we're doing. See a guy like this, good-looking guy, great blue eyes, but the puffiness of the lower lids, we just want to smooth that out a little more. And here's a gal, here's a little trick. What I do sometimes in the office to more accurately identify the pouches, I have somebody keep their chin at sea level, just static, and I have them look up. That will help us clearly define where the fat pouches are. So there she's doing it post-op. Okay, we go from there. She's a good-looking gal, great skin, but she had that sort of chronically tired look. Similar thing, just to smooth that out, much more vibrant, much more relaxed. Again, puffy eyes. See, don't her eyes kind of pop more? You see that? What I mean, the designers say, pop. Here's a gal with just puffy upper and lower eyelids, smooth those things out, etc. Okay, now, before I go on, I want to talk about something very important. Sometimes more women than men come in and they ask me about the pouches on their cheeks. And they say, can you do a lower eyelid tuck for me? We've got to be very careful because that's edema. That's fluid. When people say, it's much worse in the morning when I wake up, and after I walk around for a while, it smooths out. To address that surgically is not the first way we take care of that. There's other things we can do, head elevation, pull packs, etc. Okay, what about position of the lower lid? As I said, as the lid ages, we not only have what seems to be extra skin and pouches, but the actual position of the lower lid can descend as we lose fat in the cheek. Okay, as the cheek comes down, it tends to pull down the lower lid. Now, what a person like that needs is to, oh, and again, there's the ideal. See the lower eyelid even gently sloping upward? Now, there are supporting structures of the lower lid called the canthus. There's the medial canthus and the lateral canthus. When someone has a very lax lower lid, we need to shore that up and tighten it up. Not only does it look better, but it protects the cornea, it protects the eyeball better. When I go to the outer one, that's a lateral canthoplasty. When I go to the inner one or medial one, that's a medial canthoplasty, etc. I can shore that up and tighten it up, improve the support. Again, she just got she hardly needed anything done except to just improve the support for her lower lid. Excuse me. So here's a gal who looks like she has really, really quite pronounced lower eyelid fat compartments. She does, but primarily her secondary problem was a laxity in the canthus. So we need to shore that up and tighten it up because that holds that membrane against where the fat needs to go, and it helps to keep that in place. So really, a lot about facial rejuvenation and eyelid rejuvenation is putting tissue back where it's supposed to go, instead of just removing it. Now, briefly I want to talk about reconstructive eyelid surgery, VFO, that's visual field obstruction. There's lash ptosis, tube ptosis. Lash ptosis is where the eyelids rest on the lashes. Ptosis, tube ptosis is where the eyelid itself is down to such a degree, the upper lid is down to such a degree it obstructs the vision. And then ectropion is where the lower lid is coming away from the eyeball. So she has an early obstruction on the right side as opposed to the left side. We even those things out. So that's how I address the muscle that lifts up the lid. Here's a guy who noticed his left eye was so tired when he watched TV at night that he had to physically pick it up. So we correct that by strengthening and lifting up that levator, reattaching it. Here's a gal who had so much skin it was obstructing her vision. Again, that's visual field obstruction relief surgery. That's a reconstructive procedure. Here's a guy whose brows and eyelids were so low that it was obstructing his vision. Again, these are eyelid tucks, etc. Now here's a gal with ectropion. See how her lower lids are kind of pulled down below her cornea? It needs to be up to a higher position. That's a lateral canthoplasty. Not only looks better, but improves the barrier, improves the guarding of the eyeball itself. There's a gal with more severe ectropion, lower lids being pulled down, improve the position like that. You see the difference between that and that? And again, I think this is visual field obstruction. Yeah, visual field obstruction. Again, almost unilateral visual field obstruction with ptosis. Pick those up, even them out. Looks better. Also, the more light coming into the eyeball. Here's a gal with very profound visual field obstruction. help pick that up, and it looks better, right? I mean, functional surgery and aesthetic surgery. Okay, now I talked about some adjacent structures. I guess I'm going to pick up the pace. I don't want people to get too tired or sick of hearing my voice. As I said, as we mature, we lose fat in our face and our hands. We gain weight in our trunk. As the mid-face gets a little bit deflated, it tends to be affected more by gravity and pulls down in the lower lid. So one of the things that I do when I evaluate the lower lid, I look at the cheek itself, right? The malar area, the zygoma. So again, here's a gal who had some lateral brow ptosis and also some mid-face ptosis. So sneaking in through the temple hair-bearing scalp, I can come down and lift up part of that cheekbone area, just to give her a much more kind of a vibrant look. Okay, so when I talk about the mid-face and the cheek, we need to think about volume. Instead of just pulling real hard and removing extra skin, like maybe a traditional facelift used to be, we want to think more about volumizing. That's what I call the volumetric facial rejuvenation, especially of the mid-face. We want to do some volumetric restoration. Fat grafting can be very helpful. Fillers can be very helpful. I like to reposition the fat compartments in the soft tissue instead of just pulling real hard and cutting off. Because we don't want a flat mid-face, right? We don't want the appearance of a flat face. Okay, I told you I would return to this drape and raisin principle. For the mid-face, think of a baby child. Think of a grape, hydrated, full, right? Rich, well hydrated and moist. Put it in the sun for a while, right? It becomes a raisin. So instead of pulling real hard on the skin and just cutting off what seems like extra, let's volumize, let's reposition, let's sort of refill. Volumetric mid-face restoration. So again, it's that full mid-face that we really value. I call this the arc of beauty, from the lateral brow to the side here and down to the cheekbone. All the models, all the gals and guys want a full mid-face. So I get to that area in different ways. Small incision in the hair-bearing part of the temple, sometimes a short incision in the crease here. Everybody's got a crease that runs along the little tragus, this part of the ear. So here's an example of a mini lift with some volumizing. So she had just a mini lift and revolumizing of the cheekbones. See how we get a little more of an upward oomph as opposed to sort of even keeled almost downward. We want a little bit of an upward arc. Okay, so here's an example, excuse me, of repositioning, revolumizing. It's, once again, instead of just pulling hard and removing extra skin, we want to revolumize. Okay, get the idea that she's got more volume in there? Again, sort of a deflated look. As we grow older, we lose fat in our face and our hands, and we gain weight in our trunk. So instead of just pulling extra skin, let's revolumize. You get the impression that she's almost a little wider. Okay, think of a child or a baby with like big, fat, full cheekbones. Okay, see, that's kind of a deflated look. So let's reposition, remove a little extra skin, of course, but revolumize. We need to have a full mid-face. Again, when you look at her, you can almost say that it looks just a little bit deflated. Good-looking gal, but just needs to be repositioned and refilled volume. This is great. Fat grafting is great for some men and some women who get the kind of hollows underneath the cheekbones. That's called submalar hollowing. Really good for that. Okay, so let me return to the concept of fillers. I talked about fat grafting. I want to talk about fillers a little bit. Here's a gal, really good looking, pretty eyes, but she noticed that she just didn't have the kind of cheekbones that she had at one time, and she wanted a little bit more prominent cheekbones. So filler, we can take off the shelf. It's sterile, get a syringe, right? We attach it to a needle and inject it. Can you see her cheekbones? We go from there to there. See, just a little more full, so it catches the light. We got a nice light reflex there. Okay, so I want to talk again about the eyelid cheek junction. This gal I did with fillers, not surgery. So if we look at her lower lids, she came in saying, you know, I don't really want a big operation, but I want to minimize the pouches. So let's look at let's think of the pouch as a mountain or a hill, and let's look at that tear trough as a valley. Okay, so either we can take down the mountain and the hill, or we can fill up the valley. She wasn't really ready for surgery in terms of marginal, so what I did was fill in the valley. Okay, everybody get that concept? Here's the mountain, here's the valley. Instead of taking down the mountain, let's just fill up the valley. So, fillers only. Does that come across? She's much smoother, right? Yeah, so we go from there to there. That's fillers. So we fill up the valley. It's another use for it. Okay.
Excuse me, how long does that last, the fillers last?
Great question. Depends on the filler that we use. Roughly 4 to 6 months. Now, Juvederm itself and some of those fillers actually encourage new collagen deposition. So it can actually result in permanent change, more collagen being laid down. So a lot of the hyaluronic acid fillers, they certainly don't last forever, but it does result in more collagen being laid down, the body's own natural protein. Okay, so what about some mini lifts of that area? Limited incision facial lifts. Please keep in mind, every client needs a custom designed approach. This is facial rejuvenation primarily of the mid-face, some of the lower face, through short incisions. Shorter incisions like that. Again, here's a gal who just got a mini lift with some volumizing. Okay, starting to get the idea. Instead of making a long incision, we're going to volumize and do a shorter incision. Can you see how the smoother that is? Here's another gal. Little pick-me-up, little mini lift, little volumizing, smoother. Again, similar thing. I think she came in wanting fillers only around the mouth, and I suggested to her, just have a mini lift, which is going to last like 7 to 15 years, have some volumizing of the cheekbones, and just have a smoother result, longer lasting. Again, mini lift with some volume. Now, most of these people, they don't need like the whole huge downtime of a whole huge facelift. Mini lift, volumizing, get the idea? Similar kind of thing, volume, mini lift, smoother. Again, this gal was concerned about her neck. She was not really a candidate for a whole huge neck lift, which I love doing, but everybody gets a custom designed approach, right? People should get what they need. That was done in the office. Similar type thing. Mini lift, done in the office, volumizing. Smoother. Okay, now I just want to show a few cases. I'm going to wrap it up here. Oftentimes people will come in, they just want the eyelids done, the brow, mid-face, whatever it is, just what we call peri-orbital. And sometimes they want more of a change in other areas of the face. We can do the neck, mid-face, and eyelids at the same time. We can do just the upper third of the face, etc. I'm just going to show you some combination approaches. So here's a gal who had her lower eyelids, upper eyelids addressed, but she had some volumetric restoration and some repositioning. Okay, see how she has more, you can almost see more volume in her, right? From the side, address those lower lids, pick that up, restoration of the neck. It's good for guys too, volumetric restoration. With repositioning, right? Repositioning, lifting, filling, right? Now, see, in my mind, since this is more Northern California, Central Coast, in general, I don't want to insult anybody from Hollywood. I used to work in Hollywood. I was chief resident at USC. But I think in general, people here want a more natural look, right? And people don't, in general, don't want to look overly tight, overly stretched. They want to look sort of more vibrant, right? More. So here's a gal with puffy lids, a little bit of change in her neck and jowls. Again, side view, a little bit of puffy lower lids, address neck and jowls. Here's a guy, just some lax tissue, a little bit of more of a vibrant look.
What are you doing to the nets?
That's a great question. You know, I think we're going to, Let's see, gals, we have another seminar coming up. I talked for an hour about neck and jowl rejuvenation. It's one of my favorite things to do. I love to do what I call the natural neck lift. But you know, I don't want to bore, I don't want to wear people out. I can talk for an hour alone on the neck. Very conservative rhinoplasty, but let's bring the jaw, let's bring the chin forward just a little bit. Much more balanced. So again, part of these principles apply, in my mind, these concepts of beauty and being attractive apply to every ethnic origin, every ethnic group. So, let me wrap up now. A well-informed patient is a relaxed patient. Okay, now, I want to talk a little bit about where we do these things and recovery, etc. Somebody asked a great question. Now, I want to go over 3 different options where I operate. People can come in the office. They take an oral sedative, an oral narcotic, and an oral antibiotic. Okay? That's by mouth. You let that stuff kind of take effect. Then I numb up the skin with a needle. That stings. Once the skin is numbed up, I can numb up the deeper tissues. So we let that soak in. So the effect is that someone will be relaxed. We give them an oral sedative. We numb them up. They can mellow out, but they're awake. So that's for people who can sit still and have a procedure. It's for people who can tolerate a needle. It's for people who can hear Danielle and I maneuvering around. Now, I'm not judgmental about it. I'm not judgmental about it, but that's for people who can tolerate that kind of thing. And generally, if people are really honest with themselves, you know what it's like when you go to the dentist. You know what it's like if you have to have another medical surgical procedure. But that's what we can do in the office. Generally good, you got to be in good health, safety first, everybody's monitored, but that's oral sedation. Now, what about at the surgery center? I have a surgery center, I'm part of a surgery center in my building. So, they start an IV. They give those same medicines right into the vein. And you can tell the anesthesiologist how deep you want to go. You may want to get just kind of twilight, you may want to get sedated, you may want to take a nap. That's perfect. What I really like is when we numb up the skin and deeper tissues for somebody to be out, even for 60 seconds, because that takes away the painful part, and then people kind of come to and they're all numb. Then we do the procedure, and then I talk to them in the recovery room and go home. Now, what about the hospital? I have privileges here at CHOMP. I'm the chairman of the division. That's for people who need a longer operation. For sure need a general anesthetic. Certain medical conditions, we go up there. A lot of the times when it's mixed insurance and cosmetic surgery, we go up there. Sometimes when it's insurance covered, we either go to the surgery center or the hospital, etc. If somebody knows that they're going to stay overnight, that can be done at the surgery center or it can be done at the hospital. So, 3 different places: office, surgery center, hospital. Both the surgery center and the hospital are licensed, accredited, and coded.
And come.
Yes. Licensed, accredited, and certified. Licensed, accredited, and certified. And in the office, we do the oral sedatives. Okay, so somebody asked a very important question. After about any operation I do, I tell people you've got to rest and take it easy for 3 days and 3 nights. That just is your time to listen to music, watch videos, do emails, write letters. If anybody writes letters anymore in the world, I don't know if anybody does. So 3 days and 3 nights. It doesn't mean lay in bed. I encourage people, get some fresh air, but take it easy. On day 4, a little bit more activity, but don't get your blood pressure up high. On day 11, slowly get back to your life. Okay? We follow people frequently. I see people the day after surgery. Danielle helps me change their bandages. Generally, people come back about 3 days later, then a week later. I use lots of absorbable melting stitches. On occasion, I take stitches out. I use stitches that need to come out or staples. But we follow people frequently. But the key take-home lesson for this is, and I tell people when you're going to schedule surgery, you've got to be honest with yourself. You've got to look at the calendar and reserve 3 days and 3 nights to just be mellow. It doesn't mean, oh, I've got 3 days off from work, I'm going to rearrange the furniture, or I'm going to empty out the attic and clean up the garage. That means listen to music, listen to your favorite old Beatles record, or your favorite classical music, whatever you want to do. Now, complications in plastic surgery. Anytime there's an incision made, there can be a complication. We've got to take this seriously. Complication rates, I think, are really low for this kind of plastic surgery. A hematoma, that's bleeding, bad scars, tissue loss, infection, wounds can come apart, that's dehiscent. Nerve problems, uneven results. The only guarantee I give people is that they will be imperfect. Nothing is perfect. These are handmade operations. Possible need or desire for further surgery. So, sometimes people come in and they say, what is my operation going to be like? And what am I going to be like? I think this Vectra system that we got really helps. It's a six camera system connected to a computer, and it allows us to take your photograph in 3 dimensions. We can see on the computer, and we can rotate you. You can point out what you like. You can point out what you like, what you don't like. It can help us size women for breast augmentation or breast reduction. To me, it's amazing. It has built into the software every breast implant available in this country. So a woman can sit there and say, what about 360 cc's made by Allergan? We just press the button and all of a sudden, zoom. It's amazing. Then she can say, well, what would I look like with a t-shirt? We press the t-shirt button, it's her body in the t-shirt. And she'll say, well, what about in a bikini? We press the other button and all of a sudden, that's her in a bikini. So somebody can see a potential neck lift from the side, but more importantly than that, a person can communicate with me and point out in 3 dimensions what they want to affect, what they like, what they don't like, etc. So, treatment and operation selected, inherent healing ability, compliance, leads, rest for 3 days and 3 nights. Surgeon skill, that's important. But the most important factor in your result will be what you look like or what you were like beforehand. So safe, high quality, effective, creative, personalized plastic surgery. Everybody deserves a custom designed approach. What are your goals? I like people to come in and tell me what they want before I tell them what I think. Aesthetic concerns, how much time off can you take? Can you tolerate risk? What is your existing condition and appearance? And cost factors. Sometimes people will come in, they say they want everything at the same time, just one convalescence period. Other times they'll say, let's do the eyes this year. Next year I'll come in for the neck, etc., whatever. Okay, 5 more minutes, is that okay? Or am I wearing people out? Concepts of beauty. There's a lot being investigated and written and explored about why we think certain faces are attractive, what's attractive to us and what's not. We don't always know why we think a face is attractive, whether it's a man or a woman, black, white, Asian, etc., but we sure know it when we see it. There's a lot of research being done about the golden ratio. There's a magic number, there's a magic ratio. It applies to men, it applies to women, it applies to black people, white people, etc. I think these concepts of beauty are timeless. And it's not really all that about symmetry. Now, Lauren Hutton has a little quirkiness to her. She's got a little bit of that dental diastasis. When we see something that's unattractive, we may not know why, but we sure recognize it. When we certainly recognize attractive faces when we see it. Well, the divine proportion, there's a ratio, 1 to 1.618. You notice this television? It's rectangular. It's not a circle. It's not a square. You look at most paintings, the ratio of it, if you measure the width to the length, 1 to 1.618. That also applies to the face. Many great artists, scientists knew about this. The Mona Lisa, the ratio of the height to the width is 1 to 1.618. When I talked about ratios, we can apply these sort of ratios. It's called the mask of beauty to attractive people's faces to help us. And it really is true that we're geared, almost in our DNA, to recognize certain mathematical relationships. It's timeless. Same thing applies. Now what's amazing is we can look at famous buildings, the pyramids, follow these ratios, etc. Attractive teeth have that same ratio, 1 to 1.618. That's all true. Now, there's another thing called the Fibonacci series in nature. A Fibonacci series is a series of numbers. 1 plus 2 equals 3. 2 plus 3 equals 5. 3 plus 5 equals 8, etc., etc. As you carry that series out, it becomes closer and closer to that golden ratio of 5. 1 to 1.618. The Parthenon, one of the most famous, beautiful buildings ever built, is full of that ratio. 5, 1 to 1.618. If that's not enough, the car show was a few weeks ago. The ratio of a beautiful sports car is 1 to 1.618. And you'll also see some of these boxy cars, they don't have that ratio. Now, if that's not enough, a beautiful musical instrument like the violin, guess what? The ratio of the sound-making part of the violin body is the ratio of 1 to 1.618. And it sounds beautiful to our ears. Beautiful trees, the ratio from 1 to 1.618. I'm not making this stuff up. If you look at the Milky Way, our galaxy, it's not totally completely circular. It's sort of oval, 1 to 1.618. It's almost like a magic number. So, speaking of eyelid surgery, some of you know I go to developing countries every year and operate on kids. We see lots of eyelid problems. This is called congenital litosis, where kids can't open their eyes fully, so we hook up some slings and do that. We do cleft lips and cleft palates, and I think it's a nice thing to do. And here's an older gal with a cleft lip, and patched her up, and the community's been very supportive, and we like doing that. And thank you very much for your attention.